of the Health and the Public Interest Master of Science program at Georgetown University, a program which emphasizes the non-medical factors that affect health and healthcare, things like healthcare disparities, the effects of the environment, pharmaceutical marketing practices, government policies, etc. And it's a pleasure today to have Dr. Anand Parekh as our speaker. You'll hear more about him and his organization that he's from momentarily. I'd like to just lay out how this seminar will run. It's going to be a brief introduction by our moderator, and then after that, we're going to have a talk by Dr. Parekh that'll last about 45 minutes. Ordinarily, the speakers have the audience muted during that time, although he may elect to elicit feedback however he wishes. For instance, using the chat is one good way to do it. So after that 40 or 45-minute talk, then we'll go to questions and answers, first by students of the program and then by the more general audience. I'd like to thank everyone for coming. This talk is, I think, the fourth in this series, and I want to remind everybody that on March 6th is a spring break week, so we won't have a seminar that day, but we'll resume immediately after that. So with all that said, Jasmine, it's all yours.
All right, well, thank you so much, everyone, for joining. So Dr. Parekh is the Chief Medical Officer at the Bipartisan Policy Center, where he provides clinical and public health expertise across the organization. The Bipartisan Policy Center is a nonprofit organization that ensures policymakers work across party lines to craft bipartisan solutions. Since 2015, he has led specific efforts tackling a variety of policy issues, including the COVID-19 pandemic, future public health, opioid crises, obesity epidemic and nutrition, health and housing, domestic and global HIV/AIDS, business and public health collaboration, emergency preparedness, social isolation, among other issues. Prior to joining the Bipartisan Policy Center, he completed a decade of service at the U.S. Department of Health and Human Services as an HHS Deputy Assistant Secretary for Health and Senior Executive Service from 2018 to 2015. He developed and implemented nationwide initiatives focused on prevention, wellness, and care management. Dr. Parekh is a board-certified internal medicine physician, a fellow of the American College of Physicians, and an adjunct professor of health management and policy at the University of Michigan School of Public Health, and an adjunct assistant professor of medicine at Johns Hopkins University. His book, Prevention First, Policymaking for a Healthier America, was released in December 2019 and argues that prevention must be our nation's top health policy priority. He's originally from Michigan and received a BA in political science and an MD and an MPH in health management and policy from the University of Michigan. A couple of fun facts. His healthcare expertise has been recognized by the Washingtonian in its listing of Washington's DC 500 most influential people, which I think is very cool. And he has a second book coming out this fall. I actually read his first book, Prevention First, a bit ago, and I can't wait to read this upcoming book. With all that, it's with great pleasure that I introduce Dr. Parekh, and we'll turn it over to him to start his presentation.
Jasmine, thank you so much for that really, really kind introduction, and thanks for the invitation from you and Adam and Elizabeth. Great to be with all of you today and talk about my favorite topic, which is prevention. So let me just share my screen here, and then we can go ahead and start. All right. Everybody good? Perfect. So I thought I'd just sort of start by talking a little bit about the Bipartisan Policy Center. We are a nonprofit organization, a think tank, and a do tank here in Washington, D.C. We were founded about now 17 years ago, so 2007, by 4 former Senate Majority Leaders, Tom Daschle, Bob Dole, Howard Baker, and George Mitchell. And the whole idea was to have a space here in Washington, D.C., where both sides could come together and we could take the best ideas from both sides to promote health and security and opportunity. And our chief audience is Congress, the executive branch as well. So we are federally focused. And what we try to do on an array of domestic policy issues. So we work on not only health, we work on energy policy, economic policy, housing policy, a number of other areas. But what we try to do is identify what are the most important policy issues facing us, what are issues that we need to educate both sides on, and what are the issues where there's a policy window, where policymakers are really focused on it, where we can do something about it. And then we identify those issues. We bring people together, not just experts, but also folks from both sides of the aisle. We don't check ideology at the door. And we try to come up with evidence-based policies that we can get both sides to agree on. And then we provide those recommendations to Congress and other stakeholders. We are a 501c3 organization, but we do have a 501c4 sister organization called BPC Action. So they can then take our recommendations, make sure they don't sit on a shelf, and be a little bit more aggressive and advocate for them on Capitol Hill. So that's how we really try to make impact. Within the health program, just so you have some orientation, we work on a wide variety of issues, everything from delivery and payment reform and health insurance, healthcare related issues, all the way to public health and specific determinants and drivers of health, like nutrition and housing. We work in tech and health innovation as well. So a wide variety of streams at any given point. And my role is really to provide that clinical and public health expertise to the organization. So thanks for the invitation today. The title of my talk is Making Prevention the Nation's Top Health Policy Priority. And I think that to many of you on today's webinar, I think you probably agree, well, it should be, why isn't it? And we'll sort of get into some of the challenges there. But let me just sort of start with the key themes. And this is hopefully what you all will take away from today's talk. The first is that prevention should in fact be the nation's top health policy priority, that it requires shared responsibility. So we're talking about individuals and families and communities and certainly the private sector, but elected officials and policymakers, I would argue, play a critical role. And to Adam's point earlier in the introduction, the important policies and systems and environmental changes, which we'll get at. There is definitely an urgency given the nation's current health trends, and we'll talk about that. No, it wasn't just COVID. This is really, we've been on a suboptimal trajectory for a number of years. And then finally, and this is a little bit biased given our orientation here at BPC, but federal leadership is critical to catalyze state and local efforts to really build a culture of prevention in the United States. So starting with this slide here, and this is data from the Centers for Disease Control and Prevention, several years old, but a very sort of simple and elegant study looking at the best states in the country and sort of the worst states when it comes from the leading causes of death in America. So heart disease, cancer, chronic lower respiratory disease or COPD, stroke, unintentional injuries, like overdoses. And if you compare those two and you just ask the question, what if all states in this country could do as well as the best states, how many potentially preventable deaths could we save? And it was really over 250,000, and this has been tracked every few years for the last number of years. But it just sort of gives you the first foray into could we be doing better than we're doing, and just looking at geography, if every state did as well as the top states, these are the number of lives we could potentially save amongst the leading causes of death. So on this slide, you see sort of a really common indicator used to sort of judge health in any country, and there are world rankings on life expectancy, and as you can imagine, we don't do very well for being sort of the most powerful country in this world. We're oftentimes in the 40th or 50th, 60th rank when it comes to life expectancy, and I think everyone sort of, your eyes are drawn to sort of the bottom of table 1 here quickly. That the onset of the pandemic, and from 2019 to 2020, that significant reduction in life expectancy, and we're still sort of catching up from that compared to other countries in the world. We fell greater, we fell more, and we're coming up slower than other countries, comparative countries. But what I really want you to focus on is the decade before the pandemic, and you'll see essentially what has been a stagnation in life expectancy in the United States. Not only a stagnation, but you see between 2014 and 2016, the first 3-year drop, if you can imagine, in life expectancy. And the last time we saw that was 100 years ago. It was sort of post World War I and the 1918 Spanish flu. So 100 years later, again, we're seeing sort of this decline. So there was a lot of stagnation even prior to COVID-19. Why? A number of factors driving that. The overdose epidemic and opioids for prescription, and then heroin, and then fentanyl, and alcoholic substance use, all of course contributing to disease and despair, sort of that constellation, including overdoses, suicides, alcohol abuse, the obesity crisis. In 1980, as you know, sort of if you looked at the percentage of Americans or adults who had obesity, it was about 10% or so, and now it's over 40%. Interestingly enough, smoking, tobacco use amongst adults was about 40% back then, and now it's about 13%, 10%. So both smoking and obesity have sort of taken sort of diametrically opposed sort of trajectories there. But certainly the obesity crisis, and then what I would call the plateauing in the decline of mortality rates from cardiovascular disease. So for several decades, we have been really on the downswing in terms of deaths from cardiovascular disease, heart attacks, and strokes. And really, think smoking, medications, interventions, all have contributed to that. But we're now seeing sort of a plateau in that decline, and certainly obesity that plays a role in that. And then, of course, the COVID-19 pandemic. So all of these, and I'll talk about that in a second, of how much mortality from COVID was preventable, but all of that has really contributed to the stagnation and decline, and that's at a meta level, right? So if you look at then disparities by income, race, or geography, you compare the richest 1% of Americans versus the poorest, critical income being a critical determinant of health, a 14-year life expectancy difference amongst men, a 10-year life expectancy difference amongst women. Certainly, if you look at race, there are racial disparities in life expectancy. If you look at infant mortality, even more telling. Geography as well. Again, if you look at certain states in the country versus the others, still a dramatic difference in life expectancy, particularly also if you look at the southeastern United States and you look at some of these metrics, they often do more poorly and suboptimal there. So stagnation of our U.S. life expectancy, I think, is just important to provide you all context of why we're talking about prevention. And then, of course, what we just came through, this monumental public health event that has had so many implications and repercussions, not just health, but in so many ways for our society. This is a really interesting study published in the American Heart Association's journal, looking at COVID-19 hospitalizations. And the study essentially concluded that up to 2/3 of the hospitalizations that we saw during COVID were actually attributable to cardiometabolic conditions in the sense that if the American population was essentially healthier, they would have been more resilient in many ways to withstand the impact of COVID. And here you see obesity at the top of the list, type 2 diabetes, hypertension, and heart failure. So another real argument for, prevention is important in of itself, health, economic reasons, and all. We'll get into that. But as we know, we're always going to be facing a variety of different emergencies. And again, being in better health individually and from a population health perspective will make us that much more resilient to withstand many of these emergencies. So I think this really sort of ties in what we've recently been experiencing, again, with the theme of preventable chronic health conditions. So let's start with maybe just asking just a couple of background questions that when I talk to policymakers, or I've talked to policymakers over the last few years, what are the questions asked and how do I respond to them? So the first question I often get is, well, does prevention really work? Whether it's through the clinical setting or the community setting, are you really able to prevent illness, to promote health? And in fact, there are evidence-based bodies, the U.S. Preventive Services Task Force looking at clinical preventive services, the Community Guide Task Force out of the CDC, independent CDC, but sponsored by the CDC, that also releases and publishes evidence-based community prevention, so outside the four walls of the clinical setting. So yes, there are an array of preventive services that have tremendous evidence. Clinical interventions like immunizations. And here are two examples here. The flu vaccine, which a lot of us take for granted, only about half of adults, really get a flu vaccine every year. But here's an interesting study from the University of Florida. They essentially modeled a poorly matched vaccine. So sometimes the flu shot gets a bad rap. It's not well matched, and then there's low uptake. Doesn't really do anything. And so they modeled, well, what is the effect compared to having no vaccine at all from a poorly matched vaccine with low suboptimal uptake? And even in that scenario, essentially we reduce, hundreds of thousands of hospitalizations and tens of thousands of deaths. COVID vaccine, for a lot of reasons, politicization as well, we have even less uptake. And this just it gives you an idea, one study of how important COVID vaccines were during the peak of the pandemic to save lives, not just here in the United States, but all over the world. So certainly immunization, childhood immunizations, really, really important. They save lives. Cancer screenings as well, whether it's colorectal or breast or cervical, lung, substance use counseling as well, screening, brief intervention, referral to treatment, tobacco, smoking cessation, tobacco use counseling, we'll get into that. So there are a lot of clinical services that have tremendous evidence and work. Community-based services, so outside the four walls of the clinical setting, certainly smoke-free policies to reduce secondhand smoke, motor vehicle injury prevention, diabetes prevention programs, which are community-based programs, which I'll talk about a little bit later, focusing on lifestyle changes, nutrition and physical activity. So there are a lot of evidence-based programs to reaffirm for those who may be less informed that in fact that prevention does work. So the second question is often, well, okay, that's great, but does prevention save money? And I think my first response is always, that should never be the first question. But if you do ask that question in about 20% of the cases, yeah, in fact, prevention can save money. If you look at clinical services, childhood immunizations, tobacco screening and counseling. Here's one example from Massachusetts. Back before Obamacare, there was Romneycare. And in Romneycare, there was a provision making all FDA-approved tobacco cessation therapies and behavioral counseling for Medicaid beneficiaries available without any barriers, no prior authorization, no cost sharing. And along with significant promotion within about 2.5 years, they saw smoking rates fall, hospitalizations fall, a return on investment, Here's another study from UCSF showing that if every state dropped their smoking rate amongst Medicaid beneficiaries by 1%, you'd see several $1 billion in total Medicaid savings. So certainly tobacco screening counseling, secondary prevention with aspirin, alcohol screening counseling, and then in terms of community-based preventions outside the clinical setting, community fluoridation, use of motorcycle helmets. So these are all evidence-based programs that not only save lives or improve health, but they also save money. And then when we talk about our $4.3 trillion or so that we spend in healthcare, you know, a lot of studies suggest that about a quarter on the dollar of what we spend in healthcare doesn't really go to improve health outcomes, and there is a portion of that that could be reduced through further prevention activities. And so, yes, there is a literature demonstrating that in certain cases, prevention can save money. Not in most cases, but certainly in some cases. But this should also always probably never be the first question. So then the next question I often get is, well, you know, all this prevention business isn't it just about people knowing to do the right thing or doing the right thing, and isn't it about personal responsibility? Or is there a component of looking more broadly at policies and systems and the environment? And as I argue in my book that Jasmine alluded to, really for prevention to work, it's really got to be both, because it's really the latter that makes the former possible. This idea of making the healthy choice the easy choice, and this is sort of the healthy default idea. And there are a number of regulatory examples over the last few years, many labeling regulations that were part of the Affordable Care Act. So now when you go to many chain restaurants or food establishments, you'll see that they have to post calorie and other nutrition information on their menus so that people are empowered to make healthier decisions. There are other examples, such as now there's a revised nutrition facts label with added sugar information. That's a big deal. Modeling suggests that over 2 decades, the consumer impact could be 1 million fewer cases of heart disease and diabetes, significant healthcare savings. Now, if that not only impacts consumers, but also causes the industry to say, hey, maybe we should reformulate things, then you can even get double the amount of potential impacts here. Voluntary sodium reduction, another thing that FDA has championed, that is now underway. You know, if we could reduce what the average consumption of sodium is to what is recommended in the dietary guidelines for Americans, then again, over 20 years, we can save substantial numbers of cases of cardiovascular disease, and you see savings there. Cigarette package warning labels, you see this in a lot of countries. Unfortunately, not yet in the United States. The FDA during the Trump administration actually went ahead with a final rule to get graphic warnings on cigarette packages. Unfortunately, the government was then sued by tobacco manufacturers, and this is currently being litigated in the courts right now. And that's why you don't see in the United States, like you do in other countries, cigarette package or graphic warning labels. But certainly there are a lot of regulatory examples where the whole idea here is yes, you know, people need to make the healthy choice, but there need to be policies to support that healthy choice, and that's why both of these things are quite important. And then the final question I get is that I think we all realize and appreciate the fact that what happens in the clinical setting really plays only a small role ultimately in health, and that's where we get into the broader determinants of health. And so there's this question, well, if that's the case, healthcare in the business of improving health, should it also contribute to or start paying for some of those services that we know from a social determinant perspective are so important to health? And you know, it's interesting when you look at the literature on this topic. But when you compare the US versus other countries, and when you compare states, and I'll just go to the next slide and then come back, and you look at the ratio between how much do countries and states, let's start with countries, spend on healthcare versus how much do they devote to social spending. In most countries, that ratio is about 2 to 1. So for every $2 of social spending, it's about $1 of healthcare spending. You see here, on the slide, the US is definitely an outlier. But for us, it's about 1 to 1. Because we spend, first and foremost, so much on the healthcare side and not getting our bang for the buck. Some could argue we don't spend as much on the social service side as well. But certainly there, it's a 2 to 1 ratio for most countries that have much better health outcomes than we do. And for us, it's 1 to 1. If you go to the next slide here, and if you look at just states, study published in Health Affairs looked at states and looked at a number of different metrics: prevalence of illness, like asthma, prevalence of obesity, and then mortality from heart disease and stroke and lung cancer. And again, what they found here was those states that had a higher social service to healthcare spend ratio have better health outcomes. And so I think this idea of the social determinants, and I think we all have talked about that, we know about that, it's really, really important. So there are a number of goals here. There are a number of ways I think we can go out and improve health, right? So one is we can leverage how much we spend on health, not 3.8 now, but 4.3 trillion, and see, are there ways where the healthcare sector can start to pay for these social services. But one could argue we should also be increasing our social service spend, whether it's education, income support, as well. There's also an important distinction to be made here in terms of social needs versus social determinants of health. So healthcare can probably only do so much, right? So they might be able to give a transportation voucher, but not be able to change sort of community design, for example. They may be able to provide meals, but may not be able to change agricultural subsidies in terms of how expensive food are, right? And so they may be able to support or help with rent, but they may not be able to, build affordable housing, even though some health systems are doing it. So I do think there's a little bit of a distinction that we ought to make there, but this is increasingly really, really important. There are a lot of examples, whether it's on the housing side, United, Kaiser, Bon Secours on the nutrition side, Geisinger, Humana had a bold goal initiative showing that essentially, if you want to improve health, reduce preventable healthcare costs, we ought to really be focusing on food insecurity and social emotional support. So there is an increasing recognition that all of these factors are absolutely critical. And really what we're talking about here is on the right here. Each of these columns, whether it's education or economic stability or food, but those drivers and determinants of health, which I'm sure you all in your class have talked about quite a bit. So here's sort of, I don't know whether they're called the $1 million question, the $1 billion question, but if all of this is true, there's an evidence-based prevention saves lives. In some cases, it can save money. Looking at broader policy systems, environmental change is important. So the question is, well, why hasn't prevention been prioritized by federal policymakers? And here I offer sort of a range of reasons and love to, during the discussion, get into your thoughts of why prevention hasn't been prioritized. The first is, you all are here in DC, so I think you can appreciate this week. We live in a pretty reactive environment, right? There's always a crisis, whether it's every day or every week or every month. And prevention, on the other hand, demands that you be a little bit proactive, right? You're thinking ahead and you're trying to prevent something from actually occurring. Prevention also requires patience, right? There aren't always what I call quick wins. And oftentimes when you get that win, you've averted something, right? So it's even harder to show that sort of victory. And sort of that's the next bullet. So the win may in fact be invisible and makes it even that much more sort of challenging to communicate the importance of prevention. Oftentimes when we talk about policymakers, those initial slides that I talked about in terms of the evidence base, there's not actually uniform knowledge about the evidence base or the power of prevention. And so increasing education is necessary. For some of this prevention discussion evokes sort of this concept of government telling people what to do in the nanny state. And I think only until you sort of have these conversations, can you really convince people that no, it's not about like telling people what you do. It's about helping them make the decisions they already want to make. But it's really empowering them and those policy systems, environmental change, supporting individuals and families to make the healthy choice. Certainly, there's elusive mandatory dollars and limited discretionary dollars. I'll get into that in the next slide. Not easy to make money from prevention in a sick care system. Unfortunately, our healthcare system is still oriented towards sort of rescue medicine, very, very reactive and waiting for individuals to get sick. And finally, you know, there is a really sort of a grassroots movement, you know, communities and coalitions and you know, different advocacy efforts demanding on a daily basis that the policymakers pay attention to prevention. So here, sort of a number of reasons why, at least from my experience here in Washington, D.C., in government, outside government, why probably prevention hasn't been prioritized. And you know, it's worth just calling the question, right? And spending a second on how much are we really spending on prevention? We talked about this $4.3 trillion, 17% of America's GDP going into health and healthcare. How much is really going into prevention? And so, you know, if you look at just, you know, primary and secondary prevention that happens in the healthcare setting, you know, the best estimates are about 5%. If you look at public health in this country, which has really yielded over the last 25, 50 years, the majority of our life expectancy gains. A very generous sort of statistic is 3%, and that includes a whole array of governmental activities, including funding for, let's say, the NIH and all, you know, which many would say is sort of not necessarily focused on sort of the prevention that we're talking about. And then primary care, the bedrock, what has to be the bedrock of any healthcare system and is critical for preventing disease and promoting health. Only 6 to 7% of the healthcare dollar goes to primary care. That's half of peer countries. And these three categories, it's important to note, they're not mutually exclusive. So there's a lot of overlap. So at the end of the day, you know, how we spend our resources really define our priorities, and our priorities define our values. And so I think the question for all of us and for policymakers is at the end of the day, how healthy of a nation do we want to be? Because if we want to be a healthier nation, then we have to be making different choices. And so I want to just spend the final few minutes talking about a couple of opportunities that I see. So if this is the challenge, what could be done from a policymaking perspective? And I am, again, focus a little bit more, given my orientation on the federal side, certainly a lot that states and locals could do, and certainly, obviously, the private sector can do a lot. But I want to just go through 5 what I think are opportunities sort of moving forward. I think irrespective of any administration that comes in to power into the White House, I think that it's one of those things where you have to be really intentional. That prevention has to be the Department of Health and Human Services, for example, #1 priority. And it can't just be sort of, you know, in words, for example, but this needs to be reflected in the annual budgets that go forward to OMB, in the strategic plans that Congress mandates that departments do. It has to be there, and then it has to be action. It has to be acted upon. There's also something called Healthy People in America. Since 1979, it's essentially our nation's health objectives. Every 10 years, there's a new iteration of Healthy People, and it includes key metrics for evaluating the health of the country. And really, there ought to be sort of a limited set of metrics associated with any administration's prevention goals and aligned with Healthy People. And every then agency within the government and Health and Human Services here, whether it's the CDC, or whether it's the FDA, or whether it's Medicare and Medicaid, or whether it's HRSA, all of the agencies should then be able to elevate prevention and really talk about how they're going to focus on prevention within their purview. So it really needs to be elevated, and I think you really need to be intentional about it. So I think that the second area is really tapping in to our healthcare spend in this country. You probably heard this term of value-based healthcare transformation. We've been talking about it for now about 15 years or so. This idea that we ought to pay healthcare professionals not just based on how much of a service they provide, but on how much of a benefit or an improvement in outcome that service results in. And that's this whole idea or paying for quality. And really quality metrics are at the heart of value-based healthcare transformation. Again, this idea that you're paying based on improvements of quality. And I would say that to this point, how we measure sort of improvements in outcomes and quality been really focused on process measures, and that makes sense. I mean, it's easier to do, it's easier to count for healthcare professionals, for clinicians. It's more straightforward. There's been a movement now to look at outcomes, to look at patient-based metrics. I think we should even go beyond and really introduce what are called health status measures. So it shouldn't really be about only how well have you managed a particular chronic condition, but how about how well have you prevented a chronic condition within your patient panel? So looking at the prevalence of chronic disease risk factors within a panel of patients, the incidence or new cases of chronic diseases within a population, really increasing accountability for healthcare providers. I mean, all the resources are there. The accountability should also be there, not just for the management, but for the prevention. And I think it's really connecting and the clinical community-based partnerships, since so much of this happens outside the clinical setting, that's what we really need to facilitate and incentivize to really reduce the incidence of a lot of these preventable chronic diseases. Here's an example of a metric that had been studied that's not yet live, but again, looking at the number of patients with an initial BMI over 30 who have achieved at least a 5% reduction in weight, which is meaningful, which is clinically meaningful within 9 to 12 months during the reporting period. So for example, right now for obesity, the metric may simply be screening, or the metric may be how many people are on a particular therapy. But this is really getting into sort of the prevention. If it's BMI over 25, it's prevention of obesity. If it's BMI over 30, prevention of, let's say, morbid obesity. So depending on the metric, you can focus on what you're preventing in, but really trying to bring these metrics to be a little bit more upstream, so you're not just focused again on responding to a condition, but you're trying to prevent the condition in the first place. So a third idea is, again, outside the healthcare sort of setting, scaling community-based prevention programs, and there are now an array of programs. If you look at networks across America, whether it's the YMCA, whether it's area agencies on aging, various other sort of community-based networks, there are an array of programs that have an evidence base that are being offered to members of the public. Falls prevention programs, physical activity promotion programs, chronic disease self-management programs. There's something called the Diabetes Prevention Program now, which I alluded to earlier in my talk, that is actually covered by Medicare through a separate pathway, but allows for individuals who have prediabetes, who are overweight as well, to enter into this program to reduce the progression to diabetes. So there are a number of programs right now that are out there. Unfortunately, a lot of them, the way that they're funded, they're dependent on philanthropy, or they're dependent on sort of in-kind support or pilot programs. But the real disconnect here is, look, if you had an evidence-based drug, let's say, or if you had an evidence-based device, right, there's a very, very specific pathway. You need to go to FDA to obtain sort of a safety and efficacy stamp of approval. And then you go to Medicare and Medicaid, CMS, to obtain their reasonable and necessary stamp of approval, and then it's paid for. But there is no analogous pathway for a community-based prevention program outside the clinical setting oftentimes given by, provided by lay persons or non-clinical providers, there really isn't any pathway. And so one of the things that I did in my book was sort of to outline what a parallel pathway could be, where you had different agencies looking at effectiveness, and then also CMS considering for coverage a lot of these evidence-based programs, again, that are outside the four walls of the clinical setting. And that's not the only way to do it. Certainly, there are other ways of doing it, where you sort of incentivize partnerships between clinicians and community-based providers, and through value-based healthcare transformation and different payment models. There are other ways to do it, but here's one way where we can better tap into a lot of prevention programs and services that don't need to occur within the healthcare or clinical setting. Sort of fourth opportunity, and sort of on the coattails of COVID, this should come as no surprise, but we need to really expand our public health investments. Certainly more accountability is important, but targeting public health investments is really important moving forward. And the best research, I think from the University of Kentucky, suggests that we have, when you look at what are called public health capabilities, those things that every community, every health department ought to be able to do: surveillance, epidemiology, laboratory, policy work, communications, community engagement, all of that work. For every community to do that, we have about a $13 per capita gap in funding that. So every community has that to assure the conditions of populations can be healthy. So that's about $4.5 billion annually. And we've done work in this area. There is now legislation in Congress to create what's called a public health infrastructure fund that would fill this gap. We're still working on it to become bipartisan, but we need to do a much better job in supporting the public health infrastructure. There is funding from COVID right now that is supporting the infrastructure. CDC has a big public health infrastructure grant. However, that's sort of one-time funding. That's a couple of years, and we keep on seeing all these sort of peaks and valleys and troughs, right? So the funding comes and the funding goes. The whole idea here would be long-term sustainable investments. We also need more focus on community prevention, supporting states and localities, and making, again, policy systems, environmental changes, the healthy choice, the easy choice. We have experience here, the federal government does, in supporting states and localities, whether it's in physical activity, nutrition, and obesity prevention, whether it's in smoking cessation, tobacco use prevention. There are examples here of programs that have improved health outcomes, modeling to suggest that money has also been saved. We need to invest in community prevention. And then again, sort of post-COVID, just to put out there, we need to be prepared for the next event, and that takes sort of a lot of things, which I won't get into here, but there needs to be, when we talk about targeting public health investments, some bridge funding between preparedness dollars, which are important, and then a crisis happens and we're looking for Congress for supplemental emergency funds to quickly respond, right? There has to be sort of something in that middle there. So Congress did create many years ago a public health emergency fund to do just that. If there's a crisis, you can quickly tap into that fund and respond. Unfortunately, guess how much money is in that fund? $0. So it's never been, so Congress has never put, they've created the fund, but they've never put money in that fund. So these are sort of the policy changes that we need, again, to enhance our preparedness, to enhance prevention, in this case, when there's a crisis that we need to respond to. And then finally, just a bit about sort of prevention research. So we spend a lot of money in this country on health research. People turn to the National Institutes of Health, $45 billion budget there, heavily skewed in the biomedical sciences. Here's an estimate. It's about a decade old, and the reason I have that is because I haven't seen a newer one, even though this is a good reminder for me to look for one. But in 2012, the best estimate of how much NIH in its portfolio spends on the prevention side was about 19% of their budget. Nutrition, and obviously obesity is a big part of prevention. The estimate of NIH's nutrition research was about 5% of their budget. And for cancer prevention, it was about 5%. So, are these numbers low? Could they be higher? Seems to be. What's the right number? We don't quite know, but at least it gives us a little bit of baseline. Where do we need prevention research? Well, we need it in the underlying biology. We need it in sort of behavior change, so sort of social science, and we need it in policy implementation. So there are a lot of areas where you can focus on prevention and prevention research. And another reason why, at least from a BPC perspective, why this is so important, as many of you know, it's the Congressional Budget Office that really helps elucidate for policymakers the legislation that they are considering. How much money will it cost to the federal government? And that's pretty important in today's day and age when the deficit, the debt, fiscal jurisprudence, budget neutrality, all of these issues are really important. And traditionally, the Congressional Budget Office looks at 10-year scoring windows. But we know, right, from prevention, whether it's done in the clinical or community setting, but oftentimes prevention takes longer than 10 years to see the benefits, not just for health, but for other areas. And so now there's some bipartisan legislation in Congress that's been out there for a number of years, but it's making a little bit more progress than previous sessions to really allow members of Congress to ask CBO, hey, if there's something related to disease prevention or health promotion, don't just give us sort of the 10-year projection. We also want the 20-year projection, and we want the 30-year projection. So then we can really see the benefits of prevention, and that could then help policymakers as they think about, well, these things might be good, but it's gonna cost a lot of money. But let's look at it over the long term, and that's really what the Preventive Health Savings Act really gets at. So these are just sort of 5, I would say, opportunities. I think there are lots of other opportunities really to elevate prevention. But I think I go back to sort of the key themes of this talk in the sense that, look, this is an area that I think we all agree is really important. It's an area that we often take for granted. It's an area that often doesn't get the attention it needs. It's sort of overshadowed. But given where we are as a country, looking at health trends, healthcare trends, it really needs to be a top priority. And policymakers, particularly at the federal level, really have an opportunity to make a great contribution. So maybe with that, Jasmine, if you don't mind, I will turn it over back to you, and really looking forward to engaging in a dialogue discussion and answering your questions. Thanks, everybody.
Yeah, awesome. Thank you so much, Dr. Parekh, for a very great presentation. You've given us a lot to think about in the prevention space. Now we'll open the floor for questions. We'll go ahead and start with HAPI students and then go to others. So if any HAPI students have a question, please feel free to raise your hand or and I can call it. I can also go ahead and start off with the first question while folks think of some questions and digest the presentation. So I think this is a really great area to focus on prevention efforts. My question is, how can we more directly attribute dollars saved by investing in prevention efforts? I think that it's very attractive talking point to policymakers who are more hesitant to invest in prevention efforts, to your point during the presentation on not seeing the direct immediate benefit. And I don't know if there maybe could be rewards, like a reward type system to more directly tie dollars saved with investment to prevention efforts to investing in other places in healthcare that may need funding, like for expansion of vision and dental services for Medicare recipients, for example. I think this was something that was used in the IRA when you included the Part D negotiation piece, and that paid for other parts of the piece in legislation. So I don't know if there like if this has been like a thought that like you may have gone down, but like maybe just how do you like tie those two more closely together of like, hey, we can save dollars and invest in another business.
Yeah, I mean, I think it's a great question, and I think what you're getting at is can you save money on the prevention side to be used as a pay for other important things? And you mentioned the example of the vision and dental and hearing and benefits that Medicare beneficiaries don't get through the traditional program. And I do have some optimism, Jasmine, that sort of CBO, if they could look at sort of a broader window and I think if we could help them appreciate sort of the benefits of prevention. They have looked at this, but there are a lot of things out there, right? There are, let's say, these expensive obesity drugs for people with obesity. There are now cures for hepatitis C. There are things, the benefits may accrue over a longer period of time. But I think helping CBO see that and policymakers realizing that, I think policymakers were still stuck because they have certain rules that they have to go by. But yeah, I mean, in an ideal world, you'd be preventing some things, and if you see some savings there, putting it back in the system to support Americans in other ways.
Thank you. Yeah, I've like that's something I've seen that catches people's attention and gets things moving. But thank you so much for that. And then it looks like Hyundai has a question. You can go ahead. That's good.
Thanks, Jasmine. Thank you so much for your presentation. I had a question about pushback from other people when it comes to like making your policies. I understand like when you have two different sides of an issue and tensions can rise, do you have even non-political pushback when you're trying to make these policies, and what does that look like?
So when you say non-political pushback,
So like
can you say a little bit more?
So from industries who are lobbying, to
Yeah.
their profits going and stuff like that. Yeah.
Yeah, great question. And Meryl Guzner in the chat also had a similar question about what role has special interest played in frustrating more investment in prevention. Yeah, it's a problem, right? Because as I said, it's sort of our system, the $4.3 trillion system, isn't really oriented towards prevention, and in many cases, some of these policies could be taking money out of their pocket. Now, I think the theoretical way around this is this whole value-based healthcare transformation discussion we've been having now for over 15 years, and ultimately, if we can get the quality metrics right, which are the currency for value-based healthcare transformation, and we can get them beyond process measures, but we can get them not just the outcome measures, but some of these health status measures, then these entities that are getting all the dollars, right, they are then now accountable for meeting for meeting these more preventative metrics. And to really achieve those metrics, they'll realize that they're going to have to partner with community-based organizations, and it's really that clinical community-based partnerships and incentivizing those. That's our real way around it. Now, unfortunately, value-based healthcare transformation has gone a lot slower than we would have liked. We're still, a lot of our system is fee-for-service driven, but you do see in those instances where whether it's new value-based models or ACOs, entities are that much more incentivized to focus on prevention, maybe not as upstream as we would like, but in a way to improve health outcomes and reduce preventable healthcare costs. So I do think that is sort of one of the win-win strategies. There are probably others out there, but that is, I think that is one opportunity out there.
Great. And I see Anya has a question. You can go ahead.
Yeah, thank you so much for your presentation today. I was interested in a group that you touched on at the beginning of your presentation. which was the group that suffers from diseases of despair. So what I've learned about this group, I understand that the group that suffer from disease of despair are often characterized by like hopelessness, mental illness, and just general unhappiness, largely attributed to like economic status. So I was curious what you envision sort of preventative programs that you think might be helpful for this group, especially considering the obstacles that the group might experience in accessing services, either due to such like hopelessness or their economic status that might limit their ability to access healthcare services themselves.
Yeah, thanks for that question. And I think Suzanne in the chat has a similar question about sort of underlying issues that tie to mental health. And that's absolutely true because they tie into the risk factors driving chronic disease. And I think in one of the slides, sort of Humana's example, when they looked at all the different factors, they found sort of social and emotional support as what was tied to healthy days and healthcare costs more than anything else other than and sort of food insecurity. So I think these are really important issues, and then further sort of hampered, and we got further behind because of the pandemic now. But I think we need to do a much better job. So I'll give you one example on the clinical side, one on the community side. When we talk about evidence-based clinical preventive services, so there are immunizations and cancer screenings and cardiovascular screenings, we do really poorly when it comes to uptake of mental health and SUD screenings, right? So if you look at depression screening, anxiety screening, alcohol screening and counseling, uptake rate is really, really poor. So figuring out how we can collect, and a lot of these services, because of the Affordable Care Act, are free of charge now, right? So increasing awareness of these, ensuring that they get provided, really, really important. And then on the community side, there are an array of programs now, evidence-based, for example, depression prevention programs for older adults, programs that get at social isolation, loneliness, but we haven't really scaled these. So maybe hundreds or thousands of people are being helped when thousands or millions of people, need to be helped. And I think sort of scaling some of these evidence-based programs, increasing uptake of clinical preventive service programs, a lot of that would go, I think, a long ways to improving overall health and reducing some of the risk factors that are driving a lot of these preventable healthcare conditions.
Wonderful. I don't know if any other HAPI students may have a question, but there's one in the chat that I can go ahead and read while we get more questions. So Dina Harris asks, to date, insurance companies do not pay for or incentivize weight loss programs such as Weight Watchers. Do you ever see that changing?
Yeah, I mean, I think it's a good, it's a good question. And, I think certainly to tackle the obesity epidemic, there are probably about 12 different things that need to happen, that could happen. We certainly need to incentivize community-based programs that are that are showing that they have important results from a health side. And I think that is sort of the push, for example, of trying to get Medicare to cover the diabetes prevention program as an example. Unfortunately, uptake there has been quite low. I don't know whether some commercial insurance companies pay for these programs. Certainly CMS doesn't. But I think we need to sort of think about sort of the whole gamut of intensive behavioral therapy, variety of different programs that show clinical benefit. Certainly everybody's talking about drugs, but it can't be just sort of one silver bullet. It's got to be a whole bunch of things together.
Thank you so much. We'll go to Margot and then Dr. Myers.
Thanks, Jasmine. This was a really great presentation. I thought what you said about incentivizing prevention through quality metrics was really interesting. And I took a class on quality last semester, and we talked a bit about value-based payment and sort of the downsides of it too. And one thing that we learned about was like the reverse Robin Hood effect, which essentially can inadvertently punish providers who take on more sicker, more lower income patient populations. So I was just thinking if there's been any conversation about how to prevent this with tying prevention to performance, especially in terms of thinking about like incidence and prevalence of chronic disease, when sometimes there are just factors that providers can't control, especially when they're taking on more lower income populations.
Yeah, that's a super question. And I think I discuss this in my book, but I think you have to do some risk adjustment based on the patient panel. And then I think you got to grade on improvement. So you can't have these static categories, because you're absolutely right. Someone could have a much sicker patient population. So I think that there are ways through risk adjustment, as well as sort of basing this not on, all right, did somebody move from morbid obesity to obesity or obesity to overweight, but basing it on sort of improvement and the trajectory, that be taken into consideration. But yeah, this is challenging stuff to measure. And then if you're basing incentives on it, I think you do have to bring in some sort of risk adjustment.
Thank you.
So, thank you for your presentation, Dr. Parekh. I hope I didn't go out of turn, Jasmine. Did I?
Oh, no, you're great. Yeah.
Okay. So I'm sure this is nothing new, but if you look at where there's significant healthcare disparities, one way to look at it is those are often populations that are served by healthcare systems that are either run by the government or controlled by the government, right? You could look at Indian nations, you could look at the VA system, you could look at Medicaid. To what extent do you think that represents an opportunity to people who are trying to, introduce more prevention and improve the healthcare system, since they are directly under the control of the government in the cases that I mentioned?
Yeah, I agree. I think every administration has an opportunity for particular populations. You mentioned two, those served by the Indian Health Service, those served by the VA, certainly DOD, even the Office of Personnel Management, HRSA-funded community health centers and 30 million patients there served. So you're right, there are some very unique levers that the executive branch has to exert influence, and by elevating prevention, in a wide variety of different ways, they could certainly make a difference that doesn't necessitate sort of Congress sort of getting involved and coming up with some sort of bipartisan agreement. So I do think that there's certainly opportunity there.
Thank you.
Wonderful. If any HAPI students have questions, please raise your hand. In the meantime, I can go to a question from the chat box. So Turner asked, much of prevention is tied to education and diet. If we consider the latter, how might the food industry be held accountable for their role in this equation?
Great question. Well, I mean, I think that the first thing is their tax exempt status, essentially, for, they're essentially marketing to children what is oftentimes unhealthy food, and removing that tax exemption that they have, is a start. But, we're debating the Farm Bill in Congress right now, all of the subsidies going to the agriculture sector, until a box of strawberries are not 6 times, as much as a bag of chips. So we're going to have this issue. So what we're subsidizing in our country for agricultural production makes a huge difference, because at the end of the day, it's sort of a, in a cost-conscious environment. If the healthier choice, again, is not the easier choice, but it's 6 times more expensive than the unhealthier one, then we're not gonna be making the healthy decisions that a lot of people, that most people want to make. And so, I think looking at how we subsidize the sector, Farm Bill, certainly important there. Marketing of unhealthy food. I think what FDA has been doing, not just during the Biden administration, Trump administration prior to that, really pushing the envelope on added sugars, on sodium, front of pack labeling, which right now is a big priority for FDA. All of that is really, really important. So it's a huge, I think they have a sort of a huge role in sort of tackling the obesity epidemic.
Thank you. Not seeing any other HAPI students, I'll go to the next question in the chat box, which is from John. He asks, what role might occupational health and safety in the workplace play now and in the future on the prevention file?
Yeah, I mean, I think, huge role. I think, when just by nature of thinking through where do most people spend their lives if they're not at home, and if you're a child, it's at school, and if you're an adult, oftentimes it's at work. So this whole idea of health promotion, disease prevention, in the workplace is so important. And I think there's a role, we wrote a report several years ago on this idea of good health is good business. That it's important, not only from sort of just a productivity perspective, but the healthier the businesses are, the greater the consumer base is, the bigger the population, and so sort of what is done on the public health side of the equation, to make a healthier environment, should matter, because that should help business as well. So there are a lot of sort of public health business collaborations there that should be incentivized, but certainly sort of workplace wellness is important for multiple reasons. And just to say, Jasmine, I think we missed one from Suzanne about wellness checks and seniors living alone, and 911 calls, and I think that's so true. And there are studies related to back this up. Meals on Wheels, right? So this is a program, through the Older Americans Act, where a lot of vulnerable seniors get meals delivered at home. That program, even though it's focused on nutrition insecurity, has also been shown to reduce depression, to reduce falls. So there are all of these, additional benefits from that connectivity, if you will. Again, reducing social isolation, loneliness, more eyes on people who may be alone or vulnerable. So I do think that the challenge, of course, is, as Suzanne writes, is how do you scale this? And I think the more programs out there that demonstrate not just improvements in health outcomes, but also hopefully preventable healthcare costs, the more likely you can get others to, either public or private sector, to start providing more resources here. Private sector, perhaps through, pay for success or social impact bond or different financing ways there. So yeah, just saw that, so I wanted to respond to that.
Yeah, no, thank you. Apologies, Suzanne, for missing that comment. And yeah, the Older Americans Act is up for reauthorization this year, so there's a lot of opportunity there to combat loneliness, social isolation through the nutrition piece. So looks like Suzanne, go ahead.
Finding my way off mute. I just wanted to comment on your response to that. Thank you for this presentation. It's really, it's really raised a lot of questions for me. So I'm sitting back, and one of the things when you talk about funding and scaling is the issue we have is, so I'm from Ontario. So like New York State, we have some very big urban centers, some of the biggest in the country, and lots of rural and then far reaching in the north. and generally Indigenous or underserved communities. One of the ways that we've gone about trying to scale this is the police have come back to us having monitored the mental health calls that they are getting. And increasingly, the communities are coming back and saying, 35 to 55% of our calls do not need a police response. They don't even need an EMS response. And so, in the interest of healthcare, but mostly in saving their own budgets, they're looking and saying, can you help us fund an EMS team or a non-policing unit? And what we need, and this is the trickiest part, I think, is the better triage and assessment at the call-in point, because then we can more appropriately distribute the services. And then we're beginning to see the trade-offs, because these people, we have one example, if I could share it. In 1 year, 250 people visited an ED downtown in Toronto 15,000 times. So they took the less than 20% of those people and put them in supportive housing. So the highest acuity, which is the one that the public doesn't like supporting, like these are the homeless people, these are the, why am I paying for them? But they cost us so much money that it actually made sense. And in the year following, not one of those people went to an ED. And the number of calls and visits dropped below half of what it had been the year before. And that was just taking the top piece off. So I don't know. I mean, I really believe the social determinants of health are impactful. And we watched it during COVID and the mobile buses that we could send out. But I think the mental health issue and that isolation, the loneliness, despair somebody talked about, these underlie so much. And if we can support them that way, then nobody will ever give mental health and healthcare back the money we saved the police or that the hospitals are saving to go to the community. But if we take the pressure off, I think that's a trade-off all by itself, because then the hospitals are now doing what they need to do, and that reduces our costs. So, the reason I was interested in this, and you have lived up to expectation, is we believe we built a reactive system, and we need to build a more proactive preventative system as well.
Yeah, I really appreciate your comments, and thank you. And we struggle here in the US with some of those same issues. And there have been pilots, criminal justice programs, as well as healthcare pilots doing exactly what you're talking about and sort of rerouting folks, and providing them the stability and the services they need. We actually this year in this country now have a 988 number. So instead of a 911 number, if you're in crisis, you can now call 988 and quickly get connected. Now the whole infrastructure still has to be funded. I mean, 911 in America took good 20, 30 years for it to totally develop. But the whole idea there, again, is sort of this rerouting and where can people get the help that they need. And you're right, it's not always law enforcement, and it's to everybody's benefit. The individual, the healthcare setting, the law enforcement, if we can get them the help they need to address underlying, whether it's mental health conditions or overdose. So really, really appreciate your comments.
Wonderful. Well, it looks like we're at time. Thank you again so much, Dr. Parekh, for this wonderful conversation, discussion on this very important topic. I'll hand it over to Dr. Myers if there's anything else he wants to say, but thank you again.
Okay, again, thank you, Dr. Parekh, for a very thought-provoking conversation. And I think prevention is obviously something that's not discussed enough in this world that kind of goes from one crisis to the next. And perhaps we could greatly cut the number of those crises if we would take a moment to think about some of the things that we've heard about today and to pressure public health and political people to look at more productive ways of dealing with these issues. So thank you, Dr. Parekh. I want to remind people there is no seminar next week. Our students are on a well-deserved spring break, if I understand the calendar right. And so we'll return in 2 weeks. And John Grogan, sorry we didn't get to your question. We have a talk on related to the opioid crisis next time around. So thanks, everyone. Thanks again, Dr. Parekh, and we'll see you all in 2 weeks.